دكتورة ضارين.
طيب اوكي، رح نحكي عن الفلويد الاي في فلويد ثيرابي اللي احنا بنعطيها بالاطفال. طبعا احنا بنعطي فلويد ثيرابي ممكن تكون عن طريق الاورال وممكن تكون اي في. اورال احنا بنسميها بارنترال والاي في بنسميها الاورال هي الانترال والاي في بارنترال، لكن احنا ان جنرال نستخدم الفلويد ثيرابي as an IV medication in certain situation. هلا رح نحكي عن السيتويشنز اللي بنستخدم فيهم الاي في فلويد ثيرابي و how we prescribe IV fluid in pediatric patient. We have some definitions. Sorry ما بعرف ليش مشي. Definitions in pediatric IV fluid therapy. We have maintenance fluid, replacement fluid, ongoing losses, dehydration, body composition and total body weight, and the osmolality. رح نحكي عنهم كلهم. هلا الwater is the most plentiful constituent of the human body. Total body water has two compartments, intracellular and extracellular compartment. Intracellular account for 30 to 40% of total body water, and the extracellular account 20 to 25%. If you see this figure, this shows the percentage of each body compartment. We have the intracellular, the extracellular, and in the extracellular part we have the plasma also, which constitute about 5 to 10% of total body water. We have a complex compound mechanism that regulates the intravascular volume to maintain the plasma osmolality between 285 and 295. And this number is very narrow, so we have a complex mechanism to keep this number in this narrow numbers. If plasma osmolality increases, this will stimulate thirst and also increase antidiuretic hormone to decrease urine output. Antidiuretic hormone regulate urinary water loss. We have also role of renin-angiotensin system and atrial natriuretic peptide. For maintenance fluid therapy, why we give maintenance fluid therapy, or in which cases we have to give maintenance fluid. بس عفوا حد عنده فكرة كيف أعمل سلايد كبيرة؟ عندي صغيرة مش شايفة. لا هيك أحسن خلص. So maintenance fluid therapy, why we give maintenance fluid therapy? In this case, I'm meaning IV fluid for the maintenance purposes. And what's the content? The content is water as well as glucose, sodium, potassium, and chloride. Maintenance fluid used to replace normal ongoing losses of electrolyte from the urine and stool, and water losses from urine, stool, skin, and lungs. We have also to add glucose in different percentage, 5, 10, 12, 25% of glucose to maintain glucose level and prevent hypo or hyperglycemia. Daily water losses, we divide it in two parts, measurable, which we can measure from urine and stool, and not measurable or the insensible water loss from the skin and the lungs. This is photo shows certain type of IV fluid. You have to see them during your clinical rotation in the hospital, the component of each type of IV fluid. If we compare the preparation that we have the 0.9% sodium chloride, which we call the normal saline. We have plasmalite, lactate or the Ringer's lactate, and the albumin. We compare it to the plasma. We have different amount of electrolyte and lactic acid in each type of IV fluid. In the plasma, we have 140 millimole of sodium in 1 liter. In the normal saline we have 154 بينما plasmalite, and its name is plasmalite because it's the nearest one to the plasma. It has 140. Ringer lactate has low sodium in comparison to the plasma, and the albumin contain 130 to 160 sodium millimole per liter, depend on the preparation. Potassium also we have different ranges. Chloride, calcium. So a certain IV fluid does not have calcium, so if we need calcium we have to add calcium to the IV fluid. Magnesium, bicarbonate. Most of IV fluid does not contain bicarbonate, so if we need bicarbonate in certain patients we have to add sodium bicarb to the IV fluid. Lactate, acetate, and gluconate. And the pH in our plasma, the pH is 7.4. But in normal salines 4.5, 5.5 in the plasmalite, 6.5 in the Ringer lactate, and the albumin like the plasma 7.4. And we have the sodium to chloride ratio in the normal saline, and we call it normal saline because it has 1:1 ratio between sodium and chloride. So how to calculate the maintenance therapy, or what's the maintenance requirements in our pediatric age group? Maintenance requirements depend on the weight. So if we have 0 to 10 kilogram, we have to calculate 100 cc for each kilogram in 24 hours. So the 10 kilogram baby need 100 multiplied by 10, which equals 1000 ml in 24 hours. If the weight is between 11 and 20, we give the first 10 kilogram 100 per kilogram, so it will be 100 per 10, 1000 for the first 10 kilogram, and 50 cc for each kilogram above 11. If it's more than 20 kilogram, we give the first 1000, then 50 multiplied by 10 is 500, so 1500 plus 20 cc per each kilogram above 20. Is it clear? Do you understand this formula? Do you have problem with this formula?
No, doctor, yeah.
Okay. So it's the same, but in this table they use other way to express it. So the first 10 kilogram, 100 ml per kg per day, or you can use it in hour, which is 4 ml per kg per hour. I will not ask you about this. I will ask only about per day. So the second 10, 50 per kg per day. Every kilogram thereafter 20 ml per kg per day. So normally serum sodium concentration is approximately 140 milliequivalent per liter, and serum potassium is 4 milliequivalent per liter. This is the normal in our serum. Maintenance solution replaces normal losses. Maintenance solution does not have an electrolyte concentration equal to serum because the electrolyte composition of urine and stool is not equal to that of the serum. Maintenance fluids commonly provide a 5% dextrose solution to prevent hypoglycemia and to give some nutrients and energy. Dextrose provide energy and prevent hypoglycemia, as I said. Sodium and chloride maintenance is equal 2 to 3 milliequivalent per 100 ml of water per day. So if our patient needs 1000 ml of water, he will need 30 milliequivalent of sodium and 30 milliequivalent of chloride. So in each 100 we need 2 to 3. Potassium 1 to 2 milliequivalent in 100 ml. per day in children with normal serum potassium and renal function. So we have to keep in mind if we want to add potassium to the IV fluid, we have to check serum potassium first and renal function. If the patient has problem or abnormality in renal function like acute kidney injury or kidney failure, we should not add potassium until we make sure that he has good urine output and low potassium level. Potassium chloride is usually added to maintenance fluid at a concentration of 10 milliequivalent in each liter. For small children with weight less than 10 kilogram, and for larger children with weight more than 10 kilogram, we can give up to 20 milliequivalent per liter. How we choose our IV fluid? We have different type and different preparations of IV fluid. The most commonly used IV fluid is the normal saline, which contain 154 milliequivalent per liter sodium. Usually after calculating electrolyte and fluid requirement, the child receives 5% of D5 fourth or third saline. How we calculate this, how we know fourth or third saline or half saline. Let us try to calculate this. We have 10 months old. His current weight is 8 kilogram. He refuses oral feeding. Calculate his IV fluid maintenance. Anybody can do it?
$800 مل دكتور.
100 بر ايش؟
per day.
هلا احنا الفورمولا اللي حكيناها depend on the weight. So we have his weight is 8 kilogram.
دكتور في first 10 كيلوغرام كل كيلوغرام
Okay.
100 مل.
Okay. So ال 8 kilogram كم بده؟
800.
Okay, 800. So the amount of IV fluid needed for this patient is 800 in 24 hours. This is the IV fluid. طيب, how much sodium does he need to know the type of IV fluid?
uh, 24 ملي equivalent per day.
كيف حسبتهم؟
بده هو 800 مل، ضربت 8 ضرب 2 ل3 طلع عندي 24.
Okay, good, excellent. Either إنه نحسب 2 to 3 per kg or 2 to 3 for each 100 ml زي ما حسب زميلكم. فهو بيحتاج 24 milli equivalent sodium in 800 ml. Okay, so 1000 liter of 1000 ml of normal saline contain 154 milli equivalent sodium. I need 800 and the concentration or the sodium should be 24. So بعمل نسبة وتناسب شو بيطلع ال IV fluid preparation اللي عندي أو البرسنتج. حد عنده فكرة؟ So maintenance fluid 100 per 800 cc عفوا. Maintenance sodium 3 multiplied by 8 24 milli equivalent. Maintenance potassium 2 per 8 equals 16 milli equivalent. Type of IV fluid 0.18 glucose saline. كيف جبنا ال 0.18 percentage؟ حد عنده فكرة؟ مين يقسم 24 over 154؟ حد قسمها؟
تطلع 0.15.
اوكي 0.15. Okay, 0.15% of the normal saline. We have preparation ready in our hospital in Jordan, 0.18% glucose saline. بالكتب ممكن تشوفوها 0.2% اللي هي بتعادل الفifth normal saline، يعني هي خمس normal saline as a concentration. So we use this type of IV fluid لأنه هو الأقل concentration صوديوم عندنا، هذا ال 0.18 أو ال 0.2%. كل 1000 cc منه تحتوي على 30 ملي equivalent صوديوم. أنا مريضي بدي 24 ملي equivalent صوديوم، فأقرب IV fluid عندي موجود available بالمستشفيات اللي هو ال 0.18% glucose saline. rate of IV fluid بقسم ال 800 على 24 hour، بطلع بده المريض 33 cc per hour. بعطي الأوردر للناس بيكون عندي 800 cc contains 24 milli equivalent sodium and 16 milli equivalent potassium in a rate of 33 cc per hour. اللي انتم لما تلفوا راوند بتشوفوا هذا الأوردر اللي هو 33 cc بالساعة، أو أحيانا بيكونوا كاتبين 500 cc in 24 hour، مش حاسبينها، السيسترات بحسبوها. هلا بالبيدياتريك age group we have to calculate cc per hour to make sure that the amount is correct and ما يكون في عندي مجال لأي error بالIV fluid. اوكي سو حكينا عن replacement IV fluid. هلا بدنا نحكي عن ال dehydration، لأنه replacement أو maintenance IV fluid حكينا هي to maintain a normal requirement of the patient. Okay, dehydration is a different story. In dehydration we have losses, so we have to give extra fluid to replace the losses and to return the patient to the normal status before the dehydration. This child has certain sign of dehydration. If you look at his eyes, sunken eyes, dry mucous membrane. When we examine a baby for sign of dehydration, we have to do full examination starting from the upper part, head till the toes. We have to look for the anterior fontanelle, usually below 1.5 years. Anterior fontanelle تكون still open, so we have to touch the anterior fontanelle to see the measurement sizes and if it's the breast or bulge. If it's the breast, the patient will have dehydration. In certain cases we have bulged anterior fontanelle. مين بعرف cases أو situation بيكون في عندي bulge anterior fontanelle؟ hydrocephalus أو increase intracranial pressure. Good, excellent. So in dehydration we have the breast anterior fontanelle. The eyes بيكونوا sunken, dry with no tears. Mucous membrane بيكون dry. أحيانا بيكون cracked lip من الدراينس. طبعا برضو بنطلع على كل السكن، بنشوف السكن إذا في عندي skin turgor, delay skin turgor يكون indicate severe or moderate dehydration. لازم نشوف البلسز، الكابيلاري ريفيل، الكلر للإكستريميتي، طبعا blood pressure، الفيتال ساين، والباترن of breathing. كل هاي الأشياء لازم نطلع عليها when we assess a patient for sign of dehydration. Then any changes in the vital sign indicate severe dehydration. Mild dehydration, the patient comes only with thirst. ما بيكون في other sign، لكن الأهل بيحكوا إنه البيشنت عنده excessive thirst. Moderate dehydration بيكون في dry mucous membrane، بيكون في skin turgor، ما في tears، decrease urine output، بينما بالسيفير ممكن يكون anuric يعني no urine output at all. We classify or we divide dehydration into different types depend on the sodium level in the serum. Isonatremic dehydration when the serum sodium level is normal. Hyponatremic in case of hyponatremia, and hypernatremic when the serum sodium more than 145. And we have to assess each case by case to determine the type of management and the type of IV fluid. Dehydration is a significant depletion of body water and electrolytes. Symptoms and signs include thirst, lethargy, dry mucous membrane, decreased urine output, tachycardia, hypotension, and shock in severe cases. Diagnosis is based on history and physical examination. Treatment is with oral or IV replacement of a fluid and electrolyte. So even in dehydration, if the patient can't tolerate oral intake, we can give oral fluid to maintain hydration status. This table is the clinical sign of dehydration and the classification into mild, moderate, and severe dehydration. Mild and moderate and severe, it depends on the percentage of weight loss. So in patients with mild dehydration, the percentage of weight loss is 3 to 5%, 6 to 9% in moderate dehydration, and more than 10% in severe dehydration. So the behavior will be normal in mild, normal to restless or hypoactive in moderate. Sometimes patient be lethargic or comatose with change in level of consciousness in severe dehydration. Thirst present in mild and moderate and severe in case of severe dehydration. Mucous membrane may be normal in the mild cases. Dry mucous membrane in both moderate and severe. Anterior fontanelle sunken in the moderate and severe dehydration. Sunken eyes, deeply sunken in severe dehydration. Skin turgor decreased in both moderate and severe dehydration and normal in mild dehydration. The blood pressure will be normal in mild and moderate, but may be normal, but usually decreased in case of severe dehydration. Heart rate normal or increase, and in severe dehydration it will be high. Urine output start to decrease in mild dehydration, and the patient might be anuric in severe dehydration. So the etiology of dehydration either by increased fluid loss, the most common source of increased fluid loss is the GI tract, vomiting, diarrhea, or both, as a case of gastroenteritis, which is the commonest cause of dehydration in pediatric age group. Decreased fluid intake in certain patient who has problem with oral intake, or both of these causes. Sign حكيناهم, symptoms حكيناهم, depend on degree of dehydration. If you call to assess a patient with dehydration, you have to act fast, assess the degree of dehydration, mild, moderate, or severe, restore the intravascular volume and tissue perfusion. How to restore the intravascular volume? By giving IV fluid bolus from isotonic solution like normal saline in a dose of 20 ml per kg over 20 minutes. You can repeat this dose and reassess the patient to see if he is improving or no. Then you have to calculate the fluid deficit, which is percentage of dehydration multiplied by the weight. and you give it for the next 24 hours. How we calculate it? We have this table: mild dehydration, older children and the infant. In older children, the mild, we give it 3%, 6% for the moderate, 9% for severe dehydration. In infant, it will be 5 for the mild, 10 for moderate, and 15 for the severe. And the amount of IV fluid, the percentage, 3, from 3%, it will be 30 ml per kilogram. 6%, it's 60 ml per kilogram. 9%, it's 90 ml per kilogram. So if I told you that the patient has 7% dehydration and he is 10 kilogram, how you calculate his deficit? So if it's 6, it's 60 per kilogram. If it's 7, it's 70 per kilogram. His weight is 10, so 70 by 10, it will be 700 ml, okay? وهيك بنحسب على أي percentage وعلى أي وزن لأي مريض. فهذا الجدول هو اللي احنا بنحسب عليه للدehydration. This is the formula: fluid deficit. It's the percentage of dehydration multiplied by the weight multiplied by 1000 over 100, simplified to be the percentage of dehydration multiplied by the weight by 10, okay? So in 12 kilogram severe dehydration, 10% dehydration, his serum sodium 138, which is normal. Calculate maintenance fluid, then the deficit, and total fluid over next 24 hours. مين بيقدر يحسبها؟ Anyone? So you have 1 minute to calculate it and put it in the chat. ما حد صاحب المحاضرة.
دكتورة يعني بضرب ال 10% بال 12 ولا كيف؟
هلا احنا بدنا نحسب المينتننس والديفيسيت. هلا لكل وحدة في عنا فورمولا. المينتننس حكت لنا انه الفيرست 10 كيلوغرام 100 بير كيلوغرام، السكند 2 كيلوغرام 50 بير كيلوغرام، صح؟ والديفيسيت إلها فورمولا: البرسنتج ضرب الوزن ضرب 10، اللي هي الفورمولا percentage ضرب الوزن ضرب 10. فfor the deficit البرسنتج 10%، 10 ضرب 12 120 ضرب 10 1200. وبالنسبة للمينتننس كيف نحسبها؟ أول 10,000 50 ب2 100 فهي 1100. So this patient need 1100 plus 1200, 2300 IV fluid for the next 24 hours. اللي ما فهم كيف يسألني بعدين بعد المحاضرة. We have to restore IV fluid by giving IV fluid normal saline bolus 20 cc per kg over 20 minutes of isotonic solution. Reassess, repeat, and reassess, and calculate the fluid requirement over 24 hours. We subtract the boluses. If we give more than 2 boluses, we have to subtract, and we have to replace the ongoing losses. Example of ongoing losses: diarrhea. Each liter of diarrhea contains 55 milliequivalent sodium, 25 milliequivalent potassium, and 15 milliequivalent sodium bicarb. So we have to do monitoring vital sign, intake and output, sign of dehydration, and sign of fluid overload. In which patient we can get fluid overload during IV fluid therapy? مين هم المرضى اللي ممكن يصير عندهم fluid overload وهم عندهم dehydration. I'm treating the dehydration. Okay.
The urine failure.
Okay, in patient with anuria ما في urine output, I'm giving IV fluid. IV fluid بتجمع. good يا عزات، ممتاز. حد عنده option ثاني من المرضى غير الرينال failure؟ طيب think about it. اللي بيعرف الجواب يحطه بالشات. In hyponatremic dehydration, the definition when the sodium level is below 135 milliequivalent per liter, we have to increase the sodium concentration of 12 milliequivalent 24 hours. If sodium less than 125 milliequivalent with symptoms from hyponatremia like seizure, we have to give hypertonic saline 3%. 4 ml per kg will increase the sodium concentration 3 to 4 milliequivalent per liter. But we have usually do slow correction in patient with acute in patient with chronic hyponatremia and without symptom. Hyponatremic dehydration, we have to do deficit calculation. Sodium deficit equal 0.6 multiplied by the body weight multiplied by desired concentration minus current concentration of sodium. Do not replace sodium faster than 10 to 12 milliequivalent per liter per 24 hour. Why? Because we will there's some entity called central pontine myelinosis, rapid brain cell shrinkage with rapid increase in extracellular sodium. Because in chronic hyponatremia, the brain cell try to adapt. So if we correct it rapidly, we will complicate the process by shrinkage of brain cell, and the patient will develop a seizure, coma, and certain CNS damage. In hypernatremic dehydration, when we have sodium level more than 145 milliequivalent, we use D5 half normal saline in a rate of 1.25 to 1.5 times maintenance to correct the hypernatremia. So always assume total deficit at least 10% in hypernatremia. The aim of correction is to correct sodium in 24 hours in case of sodium level between 145 to 157. If the sodium in the serum is between the range 158 till 170, we have to correct it over 48 hours. And if the sodium level up to 183, we have to correct it over 72 hours. We have to correct half of the free water deficit in the first 24 hours in case of sodium level less than 175. And if the sodium level more than 175, we have to correct it not more than 1 milliequivalent an hour because of risk of cerebral edema. We usually use hypotonic fluid unless we have severe circulatory collapse. We can use normal saline. And the most common type of IV fluid used in correction of hypernatremia is half normal saline. In certain situations, we use oral rehydration solution to correct dehydration. It's only used in case of patient who can't tolerate oral intake. We have oral rehydration solution in a sachet. Each sachet can be dissolved in 500 ml of water, give 50 calories, and contain 2.5 glucose, sodium 50, potassium 20, magnesium 2, lactate 31, and the osmolality is near the serum osmolality 270. The ingredient is water, salt, and sugar in certain ratio, and depend on the age of the patient. If the child's below 2 years, we use 50 to 100 ml after each loose stool, up to approximately half a liter per day. If the child's up to 9 years, we use 100 to 200 ml after each loose stool. So we use oral rehydration solution to replace the ongoing losses from diarrhea, for example. More than 10 years, we can give as much as wanted, up to 2 liters per day, to replace the losses from diarrhea. This is the sachet of oral rehydration solution. It contains powder. The family or the parent will dissolve it in water and give it gradually to the patient, small amount over long time to prevent vomiting. Do you have any questions? So this is the end of the first lecture, and I will start in 2 minutes the second lecture عشان ما نطول. اوكي
دكتورة
تفضلي.
بدي أسأل سؤال.
تفضلي.
هلا خلال ال 24 ساعة المفروض أكون لما يصير في dehydration المفروض أعطي المريض الديفيسنت والمينتيننس والongoing loss إذا كان في عنده أي شيء diarrhea أو vomiting.
صحيح. هلا المينتننس لازم أعطيه لأي مريض حتى لو ما عنده dehydration. يعني إذا في عندي مريض ما عنده dehydration إله مثلا صورة رنين ولازم يصوم بالليل ambioidal fasting، لازم أعطيه maintenance IV fluid to prevent dehydration. أوكي، فبعطيه ال IV fluid as IV fluid maintenance لأنه هم طلبوا إنه يضل MBO، فبعطيه ال maintenance. هلا الديفيسيت للبيشنت اللي عنده already losses، يعني وصلني على الطوارئ في عنده loss of body weight as a loss of fluid. حسب البرسنتج أنا بحدد البرسنتج بالنسبة لمريضي حسب الإيفالويشن history and physical exam 5, 10%, 15%, whatever. I have to replace أو I have to replace this loss over the next 24 hour. يعني ببلش هلا for the coming 24 hour لازم أعمل replace. During this 24 hour, I have also to check for the ongoing losses. يعني my patient has massive diarrhea مثلا أو عنده recurrent vomiting, I have to replace the losses. Okay. So usually احنا بنقسمهم لثلاث أجزاء. العفو. Maintenance, deficit, ongoing losses. المينتننس ثابتة للمريض. الديفيسيت كمان depend على degree of dehydration، بس لما أعمل assessment بتكون ثابتة إلا إذا غيرت الأسسمنت تاعتي. يعني وأنا بنص الثيرابي غيرت البرسنتج من 5% شفت مريضي إنه 10%، بغير الIV fluid. والongoing losses usually إحنا بنوزن الدايبر. يعني الأم تحكي إنه عنده huge amount of diarrhea، بنصير نوزن الدايبر. إذا الدايبر وزنها مثلا 100 ml بفترض إنه فيها 100 ml of diarrhea أو urine وبعمل له replacement. بعطي المريض extra 100 ml of IV fluid غير اللي already كنت كاتبت له إياه. حد عنده سؤال تاني؟ طيب هلا أنا لازم أعمل stop presenting هاي وأعمل share للأذر. أوكي. اوكي هلا محاضرة الكروموسومال إذا حابين تاخذوا بريك 2 minutes ما عندي مشكلة. محاضرة شوي طويلة بس رح نمشي عليها سريعا، فيها أشياء مهمة أكثر من غيرها، لكن إجمالا يعني هي رح تتطرقوا لها لما تشوفوا المرضى، رح ترجعوا تحتاجوا تقرأوها لما تصيروا تلفوا روتيشن وتشوفوا المرضى. هي المحاضرة بتحكي عن genetic and abnormalities in pediatric. احنا بالعادة بنشوف الكروموسومال والجينيتيك abnormality بالأطفال لأنه most of them they will die before reaching adults, so الأدلت ما بيشوفوهم. So هي أشياء بس بتنشاف على الأغلب بالبيدياتريك, but certain cases أو certain genetic disorder أو chromosomal disorder they reach the adult age, بس usually كل الcomplication والمشاكل بنشوفها احنا كبيدياتريشن. As you know من أول 3 سنين دراستكم الميديسن, a human cell contain a multiple of 23 chromosomes. Haploid cell has 23 chromosomes, typically in the ovum or the sperm. Diploid has normal diploid number 46. Abnormal cells that do not contain a multiple haploid number of a chromosome, they aneuploid cell. Aneuploidy is the most common and clinically significant type of a human chromosomal abnormality, occurring in at least 3 to 4% of all clinically recognized pregnancies. The most common numerical abnormalities in live-born children include trisomy 21, اللي هو Down syndrome, trisomy 18, Edwards syndrome, and trisomy 13. Trisomy 18, trisomy 13, usually they die in the first year of life because of severe complication, cardiac and admission. بينما Down syndrome, they reach 40, 50 years of age before death because they have a lot of complication, but usually non-fatal, most of them. 6 chromosomal aneuploidies like Turner syndrome, so those are a somatic chromosome, and we have 6 chromosomal aneuploidies. Turner syndrome, usually 45 X chromosome instead of 46, and we have Klinefelter syndrome, اللي فيه 47, either XXY, XXX, or XYY. Chromosomal disorder either happened by chromosome deletions, duplication, inversion that affect whole chromosomes or large portion of a chromosome. The most common cause of aneuploidy disjunction. Non-disjunction means the failure of chromosomes to disjoin normally during meiosis 1 and 2 or during mitosis. After meiotic non-disjunction, the resulting gamete either lacks a chromosome or has 2 copies instead of 1 normal copy, resulting in a monosomic or trisomic zygote respectively. اللي بده أي إشي يسأل يعني يوقفني. هي المحاضرة راح تكون يعني محاضرة هيك فيهاش أي إشي يعني راح تكون boring يعني، فاللي حاب يسأل أي إشي يسأل. Translocations, common type of chromosomal anomaly in which a piece of one chromosome breaks off and become attached to a different non-homologous chromosome. Part من الكروموسوم بينقطع بيروح بيمسك other part of other chromosome. Mosaicism or mosaic, when only a portion of cells carry the chromosomal defect and rest of cell are normal. So part of the cell has the abnormal chromosome and the rest of the cell are normal, فبيكون mild phenotype. بيكون مبين على البيشنت إن عندهم chromosomal abnormality. Chromosomal disorders are typically identified by chromosomal analysis, karyotyping. So karyotyping هو الفحص اللي احنا بنعمله to detect chromosomal anomaly. يا عفوا الCR عزت اسمك صح؟
مظبوط.
بعد إذنك احنا كنا 51 في حدا طلع. ما بعرف اللي طلع هل هو already كان من الحاضرين ولا من اللي كان مسجل غايب. إذا كان من الحاضرين I have to know his name لأنه راح يتسجل غياب.
تمام دكتور.
Okay. Translocation is a common type of chromosomal anomaly. حكيناها sorry. So karyotyping هو التست اللي احنا بنعمله to detect chromosomal disorder. karyotyping هي عين الدم من المريض نفسه، احنا بناخدها بنوديها على المختبر بيعمل analysis للكروموسوم، بيعد الكروموسومات، لازم يكون في عنده 23 ويكون في total 23 يعني جامعة 46 chromosome XY أو XX depend on the sex and gender. Genomic disorder are a group of diseases caused by rearrangement of the genome, including deletion, loss of a copy of DNA, duplication, addition of a new copy of DNA, and inversion, altered organization of DNA. Dye-George syndrome, for example, deletion of gene located على chromosome 22q11. Genomic disorders are often identified by fluorescent cytohybridization, we call it FISH study, or by array comparative genomic hybridization, ACGH technologies. So karyotyping, we detect chromosomal abnormality. FISH أو ACGH, we detect genomic disorder. We have مصطلح اللي احنا دائما بنحكيه Mendelian inheritance. As I said, the human genome 46 chromosome. We have 22 pair of autosomes and 1 pair of sex chromosome. There are 3 classic forms of genetic inheritance: autosomal dominant, autosomal recessive, and X-linked. Usually when we take history for a genetic disease or chromosomal disease, we have to draw the family pedigree. Family pedigree have symbols: square for male, circle for females. This line between male and female mean marriage or meeting. Parent, one line, and there's siblings, one boy, one girl. This means dizygote non-identical twins if they share the same line instead of this square. And if we put a line between them and they have the same sex, they will be identical twins. If it's in black, this means affected individual. Black with arrow, this is, white with line, this means death. Half white, half black, this is heterozygous or autosomal recessive disorder, one carrier but not affected. Okay, in this means affected mom and affected child. This line, 2 lines between the parent indicate consanguineous marriage. So you have to use this pedigree when we take a history for a patient with genetic disorder or suspected genetic disorder or chromosomal disorder to know who's affected, how many, male or female, is there any carrier, and to see if there's any abortions, deaths in the family. In autosomal dominant inheritance, determined by presence of one abnormal gene on one of the autosomes, the chromosomes from 1 to 22. Change in one of the birth gene has an effect on the phenotype, physical manifestations, behavioral characteristics, or differences detectable only through laboratory tests, even though the other copy of the gene is functioning correctly. Male and female are equally affected, 50% chance of transmission from parent to offspring, vertical transmission in all generations, Parent-to-child transmission is a characteristic of autosomal dominant inheritance. Male-to-male transmission essentially confirm autosomal dominant inheritance and exclude X-linked. That's why the family pedigree is very helpful to know the pattern of inheritance. This is the family pedigree for autosomal dominant inheritance. The father is affected, the mother is healthy. So this father, the affected, has one large gene and one small, but the mother has two small, which is normal. If they have 4 children, they will have one affected baby, and the percentage 25%, one normal girl, one affected girl, and one normal boy. So the percentage is 25% for each. And this is also helpful when we do counseling for the parent with disease transmitted as an autosomal dominant, to tell them the percentage of the affected children and the risk of a transmission in other siblings. So this is also the autosomal dominant inheritance, but this go to the 3rd generation, not only the 2nd generation. So if the grandfather was affected, grandmother no, they will have one affected girl and one affected boy, and their offspring will have also 50% affected and 50% healthy. And we can see that it's also transmitted between male and female, not only female like X-linked. So certain diseases in pediatric age group, we see them commonly have autosomal dominant disorder, a very powerful dominant humans, it's from autosomal dominant, von Willebrand disease, pseudohypoparathyroidism, dystonia, osteogenesis imperfecta, Marfan syndrome, intermittent porphyria, neurofibromatosis, Noonan syndrome, tubular sclerosis, so Huntington chorea, hereditary hemorrhagic telangiectasia. You have to look at them, don't memorize, just look at them to know the pattern of inheritance. Many patients with autosomal dominant disorder have no history of affected family members, either because of a new mutation occurred in the DNA of the egg or sperm that formed that individual, or incomplete penetrance or variable expression. The autosomal recessive inheritance is different, involve mutations in both copies of a gene. Examples of autosomal recessive disease are cystic fibrosis, sickle cell disease. I think you have to know cystic fibrosis because it's a common genetic autosomal recessive disease in Jordan. Also sickle cell disease. Characteristics of autosomal recessive trait include horizontal transmission, the observation of multiple affected members of a kindred in the same generation but no affected family member in other generations. So it's horizontal, not vertical transmission. Recurrence risk is of 25% for parent with a previous affected child. Males and females being equally affected. Autosomal recessive, the father is carrier, the mother is healthy non-carrier. 2 of their offspring will be carrier and 2 are healthy. But in a case of 2 carrier parents, we have 1 diseased, 2 carrier, and 1 not affected. So this is common because of consanguineous marriages, because we have parents are carrier, the mom and the father, because they are cousins or related to each other. So an autosomal recessive inheritance, it's a vertical transmission and usually come like this. This is the third generation, have consanguineous marriages. This two line, as I said, indicate consanguineous marriages. And they have two affected siblings, two deceased. None of the family has the disease, although we have some carrier. Doesn't appear until they have consanguineous marriages. So the autosomal recessive cystic fibrosis, phenylketonuria, galactosemia, homocystinuria, alpha-1 antitrypsin, Wilson disease, glycogen storage, thalassemia, congenital adrenal hyperplasia, alkaptonuria, neurogenic muscular atrophy, Friedreich's ataxia, spinal muscular atrophy. So we have severe diseases that affect life, like neurogenic muscular atrophy, spinal muscular dystrophy. All of them will die in younger age. X-linked inheritance. Female carries half a 25 risk for having an affected son, 25% risk for a carrier daughter, and 50% chance of having a child that does not inherit the mutated X-linked. So X-linked, it's in the X chromosome. So if the mom is carrier, she has one X affected, the other X is normal. So one carrier female, normal female, one affected male because he has only one X and the X is dominant over the Y. So he will be affected male and healthy male. So if the disease is X-linked, we can see the mom transmitted to her male offspring. If the father is affected, the girl will be carrier, but no one of the male will be affected of the boys because the mom will give the X chromosome and the father gives the healthy Y chromosome, so the boy will be normal and the female will be carrier. In X-linked recessive inheritance, it will be X-linked and also recessive at the same degree. This is behind your scope, don't read it, okay? And we have also the X-linked dominant, don't go about it. We have mitochondrial inheritance. An individual's mitochondrial genome is entirely derived from the mother because sperm contain few mitochondria, which are typically shed upon fertilization. A woman with a mitochondrial genetic disorder can have affected offspring of either sex, but an affected father cannot pass on the disease to his offspring. Example for mitochondrial inheritance, the mitochondrial myopathy. Clinical cytogenetics. Clinical cytogenetics is a study of chromosome, their structure, function, inheritance, and abnormalities. Chromosomal abnormalities are very common, occur in approximately 1 to 2% of live births, 5% of stillbirths, and 50% of early fetal losses in the first trimester of pregnancy. Chromosomal abnormalities are more common among persons with mental retardation and have a significant role in the development of some neoplasm. So chromosomal abnormality lead to mental retardation and increase the risk of malignancy. Risk of chromosomal anomalies, advanced maternal age, multiple abnormalities of fetal ultrasound, multiple congenital anomaly, unexplained growth retardation, mental retardation, ambiguous genitalia, primary amenorrhea or infertility, recurrent miscarriage, more than 3 or prior history of stillbirth and neonatal deaths, first degree relative with a known or suspected structural chromosomal abnormality, clinical findings consistent with certain chromosomal anomaly, certain malignancies, and chromosomal breakage syndrome. like Fanconi syndrome. Trisomy is characterized by presence of 3 chromosomes instead of normal 2 of any particular chromosome. Occurrence of trisomy 21 and other trisomies increase with advanced maternal age if the mom is more than 35 years. Most individuals with trisomy exhibit a constant and specific phenotype depending on the chromosome. Trisomy 21 Down syndrome, trisomy 18 Edwards, trisomy 13 Batau syndrome. So this is the karyotype. This is chromosome number 1 till chromosome 22, X and Y chromosome. So this is a female girl with Down syndrome. This is the chromosome 21. Instead of 2 gametes, we have 3. So we have 3 extra 1 chromosome at the chromosome number 21. So this is a female with trisomy 21 or Down syndrome. Down syndrome is the most common genetic cause of moderate mental retardation. Incidence of Down syndrome in live births approximately 1 in 733 births. The life expectancy of children with Down syndrome is reduced approximately 50 to 55 years. In the past كانوا يحكوا لل 40, now I think it's prolonged up to 60 years. This is the typical feature of Down syndrome. You can know the phenotype presentation of Down syndrome. شو بيكون عندهم Down syndrome, who can participate. اقرأوهم, believe me رح يجي عليهم أسئلة. This is also Down syndrome. Hypotonia and bolus in head lag, vertical and suspension, and the creases اللي بتكون Down syndrome. You have to know all of them. So Down syndrome have risk for other problem like neuropsychiatric problem, autism, disruptive behavior, depression, Alzheimer's disease at early age, musculoskeletal, atlantoaxial instability, hip dysplasia, slipped capital femoral epiphysis, joint dislocation, congenital or acquired hypothyroidism, diabetes, infertility, hyperthyroid, transient lymphoproliferative syndrome, acute lymphocytic leukemia, acute myelogenous leukemia, and celiac disease, and risk of obesity. Affected individuals are more prone to congenital heart defects. The most common is the AV septal defect, atrioventricular septal defect, or complete AV canal. Developmental delay is universal, so all children with Down syndrome have developmental delay in different degree. Cognitive impairment does not uniformly affect all area of development. So they have certain area affected more than the others, so they have certain cognitive response, and they can achieve certain things in different area. Social development is relatively spurred, socially بيكونوا normal. Most male with Down syndrome are sterile, but some female have been able to reproduce. 50% chance of having trisomy 21 pregnancy. The patients with Down syndrome are at risk for leukemia, 60% of all cancer in people with Down syndrome. All women should be offered screening for Down syndrome in their second trimester by quad screen for maternal serum test, free beta human chorionic gonadotropin, beta HCG, unconjugated estriol, inhibin, and alpha fetoprotein. Screening during the first trimester by fetal ultrasound for knuckle translucency thickness. هاي رح يجي عليها أسئلة. So this chromosomal karyotyping XY so it's also female. At chromosome number 18, she has 3 chromosomes, so trisomy 18. Trisomy 18 have also certain characteristic, and they will die early in life. This is a photo for trisomy 18. This is trisomy 13. And in certain situations, they born dead. They have this characteristic finding, scalp finding, also characteristic. You have to know all of them. There is a table in Nelson. You have to know this sign and this finding. This is a table comparison between trisomy 13, trisomy 18. You have to read it and to know the differences. Turner syndrome is X chromosome abnormality. It's 45X. So instead of 46, she has 45X chromosome. Maternal age is not a predisposing factor. Turner syndrome occurs in approximately 1 per 5,000 female. In 75% of patients, the lost X chromosome is of paternal origin. So she has X chromosome from the mom, and the other X chromosome lost from paternal origin. Most patients tend to be of normal intelligence, but mental retardation is seen in 6%. So this is a karyotyping for female with Turner. She has normal chromosomes, but she has only 1 X chromosome. So missing other X, and she will be female XO instead of XX. So in Turner syndrome, there is certain characteristic also to know Turner feature, but we can detect it mainly by karyotyping. Turner syndrome usually short, wide nipples, low hairline, and associated with heart problem and other anomalies. Short stature, congenital lymphedema, horseshoe kidney, increase curving angle of the elbow. There's shield chest and wide spaced nipple. Learning disability in certain patients, not all of them. Developmental delay in 10%. Some of them can get celiac disease also. So most of the time we detect Turner syndrome during investigation for short stature. Any female come to your clinic complaining of short stature, you have to do karyotyping to look for Turner syndrome. So they have also chance to develop gonadoblastoma. American Academy of Pediatrics has recommended the use of FISH analysis to look for Y chromosome in all 45X patients. If Y chromosome material is identified, laparoscopic gonadectomy is recommended. So they said they could have Y chromosome not detected during karyotyping, so they are at risk for gonadoblastoma. So we do FISH study to know if there is a Y chromosome, and if the Y chromosome is detected, we have to do gonadectomy to prevent gonadoblastoma. Noonan syndrome is autosomal dominant disorder, affect both sexes. Feature common to Turner syndrome: short stature, low posterior hairline, shield chest, congenital heart disease, and short webbed neck. Noonan syndrome has different pattern of congenital heart disease, typically involved right-sided lesion. This is a feature of Noonan syndrome. Go through it. Klinefelter syndrome. are phenotypically male. The most common cause of hypogonadism and infertility in male, and the most common sex chromosome aneuploidy in human. 80% have a male karyotype with extra X, XXY. So they have extra X, so they have hypogonadism. Remaining 20% have multiple sex chromosome aneuploidy, 48 XXXY, XXYY, or 5X with 1Y. Each additional X chromosome reduced the IQ by 10 to 15 points. So each X chromosome will decrease the IQ by 10 to 15%. The main effect is seen in language and social domains. So Klinefelter have problem with social, but in Down syndrome, the social life is not affected. This is Klinefelter, lower IQ, tall stature, poor muscle tone, reduced secondary sexual characteristic, gynecomastia, male breast and small testicle, and infertility. Fragile X account for 3% of male with mental retardation, X-linked dominant. The main clinical manifestation in affected male are mental retardation, autistic behavior, macroorchidism, which may not be evident until puberty, and characteristic facial feature. The facial feature, long face, large ears, prominent square jaw, become more obvious with age. Female affected with Fragile X show varying degree of mental retardation and learning disability. So if you find a patient with mental retardation, autistic feature or behavior, you have to look for chromosomal abnormality like Fragile X syndrome. This is a baby with or a child with Fragile X, and the feature become more prominent when he is an adult. Prader-Willi syndrome results from loss of paternal chromosome at number 15 at a locus 11-13. Hypotonia as infant, developmental delay, mental retardation, obesity, hypogonadism, short hand and feet, bird-like head, small head, and we diagnose it by FISH, not the karyotyping, because it's a locus problem. Prader-Willi, this is the chromosomal, this is chromosome number 5. You have two chromosome number 5, but you have deletion of the lower arm of the chromosome number 5. It's either XY in 97% and XX in 3%. So Prader-Willi usually male. Prader-Willi obese, short stature, mental retardation, short hand and feet, and hypogonadism. That's it for today. Thank you. Do you have any question?
يعطيك العافية.
طيب قبل ما تطلعوا بس إذا سمحتوا أنا بدي أقرأ الأسماء الموجودين، اللي بقرأ اسمه يطلع. ما حد يطلع قبل ما أقرأ الأسماء. أوكي. بس بعد إذنكم أطلع القائمة من عندي. يا ريت يا دكتور عزت تبعث لي القائمة على الواتساب، قائمة أسماء جروبكم إذا موجودة عندكم، إذا موجودة عندك.
موجودة.